Yes, hello, hi Islamic. So everything is clear, the audio and the video. So today's class is about the back pain, and we are going to learn in a great detail how are you going to just evaluate a patient with a back pain, right? So this is supposed to be the most common complaint we see in the orthopedic department, the OPDs, right? Yes. 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 Good evening, Barnak. Okay, Nishu, good evening. Yes. Now let's start. In brief, you're going to understand what is actually this back pain and what are the various, conditions which are related to this particular pain. Okay? Yes. So let us start with Good evening, Barnak. Okay, now let us first start with the very important definition of what actually is a low back pain. So low back pain, it can be defined as a pain or just a stiffness which is mainly present in the back region. So particularly as we are the medical students, we can describe it as which is localized below the costal margin and above the inferior gluteal fold. So that is actually the low back pain. So today specifically, I want to talk about the low back pain. Right. So this low back pain is nothing but whenever a person is having or an individual is having a pain or any discomfort or maybe muscle stiffness, which is exactly below this is the costal margin, that is the rib cage, and this is the inferior gluteal fold. So near the inferior gluteal fold, the hip joints up to the hip joints, usually with or without a leg pain. So whenever it is associated, including the leg pain, or it could be without a leg pain. So this is defined as a low back pain. Yes, good evening, Osama Sheikh. I'm fine, thank you. So now this low back pain can be of two types. As we all know, any condition we can name it as or classify it as an acute condition or a chronic condition, right? So mainly you want to know whether this is an acute or chronic condition to understand its diagnosis and to guide towards the management. So as you all know, acute. When will you say the word acute? If it is less than 6 weeks of time. So usually a patient whenever is having a low back pain, usually just instant the low back pain they don't present to you. So they will take up to 1 to 3 days. They will wait for it to reduce, and if it is not reducing, then they will present to you. So usually it will be less than 6 weeks is considered as an acute low back pain, and if it is 6 to 12 weeks, it is subacute pain, and if it is a more than 12 weeks, that is chronic pain. If it is more than 3 months, so 3 months to 12 weeks, it is a chronic pain. That means the pathology has set in, and this chronic pain is usually a like it could be this pain could be a intermittent pain. So they will not have a continuous pain. It could be intermittent pain, and sometimes it can be increased only with the activity. So or sometimes only with the activity, that is if the patient is having a pain and then they will take rest, and then again with any increase of activity, like if they are doing the regular activities and they don't have pain, but if they, for example, the most of the during the month of January, where everybody wants to start gym and maintain good fitness for the new year. So usually for what they do, the first 10 days they will go to gym regularly, and which is not a very normal routine for them. So after 10 days they will have certain backache, they will have certain thigh pain and all these pains, and they will stop going to gym. Again February 1st they will start, again they will be increase in activity, again they will have pain. So this might be considered as a chronic pain, where this patient will have remissions and exaggerations of the pain, and it will be for a chronic period. It should be at least for a period of more than 12 weeks, right? So 3 months is considered to be a chronic pain. Now let us see which of the conditions will come into acute and chronic also. Okay, and now the most common complaint what you see is a non-specific low back pain, right? So the most common complaint is a non-specific low back pain, but this is also considered as a major public health problem, and to your surprise this is the second most complaint after common cold. So this is as common as your common cold, right? So this is a non-specific low back pain. So what are the causes of the non-specific low back pain we will understand at the end of the video, but now let us remember that the low back pain is usually the pain which is from the lower costal margin to the inferior gluteal fold, and then we have understood that there are three types: acute, subacute and chronic, and the most common form of low back pain is a non-specific low back pain. It is as common as your common cold. So in 70% of the cases, so most of the low back pain, that is 70% of the cases, you will not find any obvious etiology or a well-known pathogenesis. Then how do you treat these patients? You have to treat them based on other pathological symptoms, right? So based upon that, you have to understand what is causing this non-specific low back pain, and then you have to treat it accordingly. So remember, the percentage is very, very high, 70%. And one more important thing you have to remember, one more important thing you have to remember is common diagnosis is commonly correct. So whenever a person presents to you low back pain, first ask the proper history, then proper clinical examination, but always keep in your mind that this could be a cause of a non-specific low back pain. Okay? Hindi mein padao. So most of them could not understand Hindi, right? So we'll put English as the language today. Hello Sakshi, welcome. So that is the importance of the non-specific low back pain, which you have to understand, right? And now let us see, why are we so concerned about the back pain? Because the prevalence of the back pain is very high. So if you see, the prevalence is as high as 84% people will suffer with a chronic low back pain, right? And usually the disability is lasting in 10, 11 to 12%. Okay, so the chronic, most of the patients, if you see, if the 100 patients are there in OPD, 70 people are with spine problems only, and in that 10 to 12% will actually have a proper pathology in spine, and they will be suffering with the disability. So that is its importance. So you have to understand this back pain in a great detail to help the patients better. Okay, so what actually helps you to serve the patients better? So one is the history taking. So this plays a very, very important role, for which we have taken this series to make you understand how important is history taking, and as well as physical examination, which both go hand in hand. So history and physical examination is very, very important in evaluating the patient with low back pain, because you have to understand what is actually the cause of low back pain. Though you know that the most common cause would be a non-specific low back pain, but the 30% you should not neglect, right? So you, to understand which frame the patient falls in, you have to take a detailed history and a proper physical examination, right? Yes. Okay. Deepansh. Good evening, Deepansh. So now let us start with the history taking. So how do you actually take a history taking? Now let us understand that you're sitting in the OPD and a patient has arrived and he have told you that he is having a complaint. So first thing what they'll tell you, they will complain of a low back pain. So usually they come with a low back pain. Right. So now let us put this as a scenario. Now the patient has come with a pain that is in the lower back region. So this pain, when you ask instantly, they will tell you that pain is only in that particular area, or it is including with the legs. So this is the one symptom which you can instantly ask, whether it is only in that particular area or it is radiating to the legs. And once you have understood that this is a low back pain which you're dealing with, so first thing what you have to ask is, what is the onset of it? So how did it actually start? So what triggered it? So this could be a trauma, or it could be a significant incident or weightlifting. So all these causes could be a reason for initiating your low back pain. Sometimes ergonomics. So what do you mean by ergonomics? Ergonomics is your occupation. Right. So sitting, prolonged sitting in this chair. So most of the software engineers nowadays, they sit for a continuous long hours in the chair, right? And driving. So nowadays people are, traveling very long distances for their work. So this continuous driving in the two-wheelers might also put strain on the back. So you have to take a proper history starting right from the onset. So onset is very, very important to understand whether it is a mild disease you're dealing with or a significant trauma. So onset is very, very important. And then once you ask them, how did it start? And now you will ask them, what is the duration? Since how long is this disturbing your work? Right. So usually whenever the work is disturbed, only the patients will walk into the OPD. Otherwise, they will manage it by themselves, because as long as the work is not disturbed, as long as the functional disability, what we call this as, we call this as a beautiful word which is called as the functional disability. That means the patient is not able to do his actual work which is meant to do. So whenever that is affected, now the patients will walk into the OPD. Now you have to ask them, what is the duration? So since how long is this backache disturbing them? Right. And then you have to ask them, what are the aggravating and the relieving symptoms? So this is again a very important thing, because I've told you few back aches will increase with the activity. So you have to understand which work related activities are actually increasing the back pain, and what actually causes them the relief, either the rest or even the pain is there on the rest. So this is the very important point where you have to understand patient is having relief with the rest or not. Okay, this is very important. So what does the patient do for relief of the symptoms? Okay, and if he says that the rest is relieving his symptoms, that means this is not something which is related to a very serious illness. So usually most of the mechanical back pains, non-significant back pains, they relieve with rest. Even with the rest, if the pain is not relieved, then something seriously you have to evaluate. Okay, so that is the importance of to understand whether the patient is having relief with the rest or not. And then very, very important, you have to ask them what are the associated symptoms. So this is the one which will help us to come to the diagnosis. So if you see now, see if the patient is having pain, okay, and now this pain is related to pain which is radiating through the legs. So this is called as what? This is called as sciatica. So what is sciatica? Sciatica is nothing but a pain which is completely radiating up to the legs. So that is called as sciatica, right? That is called as sciatica. So whenever there is back pain with the sciatica, usually what you have to think? You have to think either it is a PIVD. So prolapse intervertebral disc disease. So most important cause would be PIVD. So it is a disc prolapse. Okay. And then next, if there is a pain, if there is a low back pain and now it is associated with paresthesias also. Okay, so there is some sensory symptoms, some disturbance and motor weakness is there, right? And now it is related to something which is disturbing the canal. So till now, if I say it is a disc problem, so you have to understand that this is the spine, right? And in between the two vertebrae, what we have the disc, intervertebral disc, right? So why are we very concerned about all this? Because there is a nerve, there is a spinal cord, and the nerves go into the spinal canal, and whenever there is a problem in the back pain, these nerves can get affected. So these nerves, when they get affected whenever there is a disc prolapse. So this is the disc prolapse, right? And if this is a huge disc, then that might result again in your what? Motor weakness and paresthesias. So PIVD, spondylolisthesis. So all this will relate to your pain with the paresthesias, right? And whenever there is a important condition, back pain with claudication. So what do you mean by claudication? Yes, so this claudication is your neurogenic claudication, what I'm talking about, right? So this is your not vascular claudication, but this is called your neurogenic claudication. So what do you mean by neurogenic claudication? That means the patient will have pain. So this pain and all this pain is usually radiation. So this is radiculopathy. So what do you mean by radiculopathy? That means it is radiating to back of the lower limb, right? So whenever there is associated radiculopathy, pain with only radiculopathy is PIVD. So if there is a pain, paresthesia, motor weakness, it could be PIVD plus spondylolisthesis. But one important condition, whenever there is a low back pain associated with neurogenic claudication. What does that mean? Neurogenic claudication means, it means the patient will walk for a certain distance and then he will have severe pain, tingling and numbness, and he can't walk further, and he has to sit and take rest for some time, and after resting for some time again he will be able to move. So this is called as claudication, right? So what happens initially when the patient is walking, there are no symptoms, the patient will happily walk. So let's take that patient is started walking, and he starts walking after a certain time, like maybe 1 meter, 2 meters. So now the patient will have severe pain in the lower limbs, and now the patient has to sit down. Okay, he has to sit down and rest, and after rest, and then he continues to walk again. After rest, again he continues to walk. So this sitting down, taking rest, relieving of symptoms, again he walks for a certain distance, again pain will come, again he will sit down, take rest. So this is nothing but this is called as the neurogenic claudication. So if you go back to a surgery, you also know that there is a vascular claudication. Similarly, you will have, this patient will have calf pain as he starts walking and all. So you have to differentiate between neurogenic and vascular claudication. So vascular claudication, initially only you have pain, but neurogenic claudication, after certain distance, the patient will have pain, that to radiating pain. Okay, there is no hyperpigmentation or something like that on the skin. The skin is actually very clear, and then only the patient will have pain with associated with tingling and numbness as sciatica, right? So this is all you have to remember, and now this will point you towards an important condition which is called as the lumbar canal stenosis, right? Lumbar canal stenosis, right? So these are the three important usually asked questions in the exam, and usually the patient present with these three symptoms. One is PIVD, second one is listhesis, and your lumbar canal stenosis. So now I think this should be easy for you to understand. Okay, so now ultimately, if the patient is having any trauma, okay, and this trauma may sometime leads to severe compression syndromes, right? And this compression syndrome, when affecting your bowel and bladder. So what is this compression syndrome which is called as? So this is called as your cauda equina. So this is called as your cauda equina. So once you have examined the patient and now the patient complains about bowel and bladder involvement, that is incontinence of bowel and bladder, then you can think of a syndrome which is called as the cauda equina syndrome. And now the second one, what you have to remember is inflammatory spine conditions, right? So inflammatory spine, so how they start? They start with a very important symptom which is called as the morning stiffness. Now the patient will tell you that he is having pain in the low back, right? So all starts with the pain, and now in this inflammatory spine condition there will be morning stiffness which is more than 60 minutes. Okay, as soon as the patient gets up from the bed, he will have severe pain and stiffness, and it will be for a long time, such as 1 hour, and then it will get reduced, right? So this is the inflammatory spine. So this is one a clue which tells you that you are dealing with the inflammatory spine conditions, the morning stiffness, right? So one example for inflammatory spine condition is your ankylosing spondylitis. Okay, so this is how you deal with associated symptoms, like you have to ask about the sciatica, paresthesia, claudication, associated hip and knee pains. So sometimes if the patient will have associated, hip and knee pains, polyarthralgia. So you can think about inflammatory conditions. So inflammatory conditions associated with polyarthralgia. Okay, so these are history taking. This is completely the history taking. So till now, so once you have taken the history, so now with the history you will understand whether it is an acute or a chronic or a subacute condition, right? So with the history you will understand that, and then you will understand what is the pathology, what are you actually dealing with. So you will ask them the exaggerated and relieving symptoms, and you will know that whether the patient is having relief with the rest or not. And then when you ask the associated symptoms, you can come to a conclusion that either you're dealing with these conditions such as your intervertebral disc prolapse or listhesis or stenosis or ankylosing spondylitis, or you're dealing with other symptoms, other systems, right? So other systems mainly because, whenever they're associated with very important symptoms such as fever, so very, very important, you have to ask them the history whether other systems are involved, right? So whenever there is associated fever, weight loss, loss of appetite. So what does this tell you? When the patient tells you that there is fever, evening rise of temperature, weight loss, loss of appetite, yes, I want you all to answer which condition am I dealing with systemic symptoms of weight loss, fever and loss of appetite. Yes, I'm waiting for your answers. Yes, Ahmad, you can get the PDF once the class is done. So now tell me one important condition which you can diagnose by knowing that the patient is having evening rise of temperature associated with weight loss. Yes, very good, Vamshi. It's the pot spine. That is your TB. So TB of spine. So usually it is the thoracic spine. We call this as your pot spine. So that importance is the history taking. So once you conclude that this patient is having other systemic symptoms like, fever, loss of appetite, night sweats, and clearly you can arrive to a diagnosis of tuberculosis of spine. And one more important thing, you have to ask them any previous cancer history, because again, the most common presentation of metastasis can be seen in the spine, right? So the most common cancers which we seen in the bone is the metastasis, and the metastasis is most commonly again seen in the vertebrae. So again, you have to take a relevant history of the patient, whether he has any previous history of tuberculosis, previous history of any cancer, right? And certain medications which might make the patient land up in osteoporosis, right? Osteoporosis with the medication, or the patient having directly decreased bone mineral density with osteoporosis, right? So how do you ask this? You ask whether there are any fractures previously. So you will ask fractures history previously, right? So you will ask history of any fractures previously, and which one are important. So the most important fractures which you have to look for are the distal radius Colles fracture, right? And fracture neck of femur. Okay, so these are the important fractures, and if the patient is presenting with distal and fracture neck of the femur, you have to ask them about the vertebral fractures. So these three are the fractures which are mainly seen in the patients with osteoporosis, right? So this is the history which you take. You will ask about the onset, the duration, the aggravating relieving symptoms and the associated symptoms, followed by any involvement of other systems like the urinary tract infections or any renal stones. So all that you ask, and then the systemic symptoms like fever, loss of weight, loss of appetite and night sweats, and any history of cancer, any history of osteoporosis or previous history of fractures, right? And finally, sometimes psychological. So some important things which you have to remember is this medicine, what we deal is like a ocean, right? So anxiety or depression, the psychological causes are also playing a very important role in certain painful conditions, especially in the back pain. So fibromyalgias, these are called as fibromyalgias, where there are non-specific causes. So this is the anxiety or depression can also lead to some musculoskeletal pain. So you have to talk to the patients and understand what is their mind condition present. Okay, and then finally you have to conclude it with their personal history, that is history of smoking, obesity, alcohol, any IV drug abuse, and finally not to neglect your work ergonomics. Okay, so smoking, diabetes, okay, obesity, and all this can again result in various decrease in the bone mineral density, right? And again patient might land up in various symptoms of the back pain. Okay, but remember, work ergonomics play a very important role, especially in the back pain. Okay, the posture in which they sit, the posture in which they work, the posture, the prolonged standing, prolonged sitting, prolonged travel, all this plays a very absolutely important role when it comes to clinics. Okay, yes. Yes, certain medications, yes, PPI can sometimes lead to your osteoporosis. Yes. So this is about the history taking. So a detailed history has to be taken to come to a conclusion. Now let us understand the importance of your physical examination. So now let us see how do you examine the patients, right? So once you're done with the history, now once you're done with the history, you should always have the working diagnosis. So you should always put a working diagnosis in your mind. So this can be 1, 2, 3, 4 diagnosis, not a problem, but at least 2 or 3 diagnoses should be running in your head, so that once you're confirm that this could be the diagnosis, then you will look for the features. So for example, let us assume that we have encountered a male patient. So this is a history. So now let us understand. So this is a male patient who has come into the OPD. Now age is very important when it comes to diagnosis. So I'm telling you the age is about 25 years old. So before starting of this history, the dermographics again play a very important role. So what do you mean by dermographics? Starting right from the age of the patient. So age of the patient, the gender of the patient, right, the family history or the socioeconomic status. The family history is again very important, and the socio-economic status. So these are all again play a very important role. So now talking about age and the gender, so certain things are common in certain genders. So for example, I've told you, now we are dealing with a male patient who is 25 years old, and now he has complained about morning stiffness. So he have told you that so he will just tell you that there is a low back pain. He will come, walk, and they will not tell, ma'am, I'm having morning stiffness. They'll tell, ma'am, I'm having pain. Where is the pain? Low back pain. So low back pain, when you will ask time, right? So what is the duration? He will tell you it is maybe some 3 months to 4 months I'm having the pain. When did it start? It started long back, ma'am, maybe some 4 to 5 months back, and it is very severe now. I'm not able to do my regular work. And now what you should ask whenever you're dealing with the young patients, so male 25 years, the first question will be your morning stiffness. So you should first ask whether the patient is having any history of morning stiffness. Now the patient will tell yes. Then you should ask, the stiffness should be more than 1 hour or less than 1 hour. So he will tell you that the patient history is more than 1 hour. And now you will ask associated symptoms. So associated symptoms may, you can ask him whether it is associated with other joints. So I'm asking about polyarthralgia. So I'm asking about what? Polyarthralgias. Okay, any polyarthralgias. So then he will tell now and then I had certain symptoms, so sometimes the back is very painful, sometimes the hips are painful, sometimes I can't sit. Okay, so any history of polyarthralgia. And then you will ask him what any other complaints like involvement of other joints and all. So there is no involvement of no other joints in hands. No joints in hands are involved. Okay, and then you will ask the systemic symptoms. So then he will tell there is no fever, right? And no loss of appetite. Okay. But he will tell, when I ask you other joints, he will tell sometimes I have these heel pains. Okay, sometimes he's having heel pains. Okay, so this is mainly the history what I took. Okay, and now I asked the social history. So everything is not significant. So there is no alcohol, there is no smoking, and all those. No alcohol, no smoking. He's not obese. Okay, so now can you tell me the working diagnosis of this particular patient? So now I'm telling you the patient is male, 25 years, morning stiffness mainly, more than 1 hour, no joints which are involved, no joints in hands which are involved. Sometimes he's having heel pain. So heel pain sometimes he's having, no fever, no evening rise of temperature, no abuse of any alcohol, obesity. So what could be the working diagnosis of this particular patient? Smaranya, am I telling too fast? So Smaranya, I'll repeat it for you, don't worry. So now we are dealing with a patient. Good evening, Arsalan. Oh, I'm telling too fast, sorry. So now we are dealing with the patient who is a male, 25 years old. He has come to your OPD with history of low back pain. So he said he's having low back pain. Then you have asked him the onset. The onset he told it was since 4 months. So since 4 months he's having this low back pain. Okay, and then he told me that there is a morning stiffness. So I asked him, is this in the morning more disturbing or in the evening? So he told me, yes, in the morning it is more disturbing. So morning stiffness is there and duration is about more than an hour. And I have asked him the associated symptoms. He told that polyarthralgia is there, but he's not very sure of the symptoms. But what is he sure is heel pain. So he's having bilateral heel pain. So both the heels he's having pain, and then there is no pain in the joints of the hand, no fever, no loss of appetite, no loss of weight, no alcohol, smoking, obesity. So this is all the negative history. Okay, now can you tell me the working diagnosis of this particular patient? So with the history, what do you think this patient could have? So with the history, when you come to a conclusion that this could be the diagnosis, this is called as the working diagnosis. So whenever a patient walks into the OPD, you first take a proper history. So with the history, you will come to a conclusion of a diagnosis, and then you will establish this diagnosis with the physical examination and then confirm the diagnosis with the investigations, right? So now we are at first stage where we are dealing with the working diagnosis. So we have finished the history, and can somebody please help me know what could be the diagnosis here? Okay, so this morning stiffness is having. So what else you want to ask the patient? Yes, you want to ask any questions or you want to conclude the diagnosis? Yes, you can ask him whether the pain is only low backache. So there is no radiating pain. Okay, so there is no radiating pain. So there is no sciatica. That means you can rule out the PIVD. You can rule out the spondylolisthesis and stenosis. So no claudication, no radiating pain. Yes, Barnack, it is. Yes, it is ankylosing spondylitis. Why it is not rheumatoid arthritis? Because there is no joint involvement in the hands. I've clearly told you no joint involvement in the hands. For the rheumatoid arthritis, it should be the joints should be involved. At least the MCP joints, joints of hands should be involved. So it is not rheumatoid arthritis. Yes, the pain is mainly in the morning, nor and sometimes even along the day. Okay, but particularly mainly in the morning. As soon as he gets up from the bed, he is having the pain. Okay, so the working diagnosis here comes up to be your ankylosing spondylitis, AS. So young male with the morning stiffness, with all these symptoms, you can put the working diagnosis as your ankylosing spondylitis. And now once you come with the working diagnosis, now you start the physical examination. So physical examination will always starts with the inspection. Yes, pain will be throughout the continuous, it will be, but morning it will be more. So once, so this is a ankylosing spondylitis only is an inflammatory condition. So inflammatory conditions, what will happen with the activity, the pain will come down. So as soon on the rest, so whole night they'll be sleeping right at rest, the accumulation will be there of all the inflammatory products, and then as soon as they get up, they will have severe pain. And once they start movement, the activity, the pain reduces, right? So that is the history. Yes, Barnak, we will go to the investigation. First, let us complete the examination. So this is only the working diagnosis. Now you have to establish it, right? By your examination, you have to establish it. So you'll always start with the physical examination with the inspection. So the first thing what you do is always start with inspection. So you will ask the patient, you will ask the patient to help them look at the back. So you will remove all the clothing and you will try to inspect for any abnormal anatomical abnormalities. Okay, so this is the one thing which you have to do. You have to expose complete area which you want to inspect. So and ask the patient to stand in the anatomical position. So once is in anatomical position like this, now you have to inspect for the shoulder level. Is the shoulder levels are at the same level? Okay, and head in the center. So head should be in the center, no tilting of the head. So whenever there is any tilting of the head, you can think of torticollis. So you can think of torticollis. So you have to inspect right from the position of the head with the shoulder level. So no abnormal movements of the shoulder or abnormal positions of the shoulder. They are at the equal level. And then what you see? You see the attitude. So you see the attitude, whether the spine should be straight. So normally the spine should be straight. If there is any deviation, you will see for the curves. Okay, so here there are two types of curves which you can notice. So first curve, this is called as the scoliosis. So the first word is scoliosis, and the second curve which you see is the kyphosis. Right, so these two you have to remember. One is a sideward bending. So what is a sideward bending? Scoliosis. And second one is a exaggeration of your thoracic kyphosis. Okay, scoliosis and kyphosis. So these are the two things which you have to look on inspection. So this you can see there is slight deviation here in this particular thing. So this could be scoliosis. Okay, and usually this is normal, a straight line. So your spine is a normal straight. Okay, so that is how you look for the attitude. You look for the positions of the scapula, right, and this spine. So this is what you see on the inspection, right? And now coming to the palpation. So next one is your palpation. So how do you palpate? So first you have to identify the various important anatomical landmarks. So C7 is very prominent, right? So C7 is very prominent. So you will identify is vertebra prominence. So C7 is usually, and you put your hand and you see the movement, the neck movement. The C7 usually doesn't move with the neck movement. So that is your C7 very prominent. And then at the end of the scapulas, you will identify it as T7, right? Thoracic T7. Okay. And at the spine, it is T4. So you will palpate the scapula and spine of the scapula where they meet, it is T4, and the inferior angle of the scapula is T7. Right, inferior angle of the scapula is T7. So you can take the help of this diagram where you see the C7 is very prominent, and whenever you see the scapular spine, it is T4, the level of the T4 at the spine. And then at the inferior angle, this is your T10, right? Sorry, T7. T7. So inferior angle is T7. It is not prominent with the neck movement. It doesn't move with the neck. So when you bend the neck like this, you can see that that particular vertebra. So you will have to differentiate between C6 and C7, right? So C7 is usually prominent in the thin individuals. You can usually identify it. But if you're confused between C6 and C7, what you have to do is you ask the patient to move the neck flexion and extension, and the C7 doesn't move. Okay. So that is C7. And at the angle, you know the spine of the scapula, you will identify the spine, and that spine level is your T4 and the inferior angle is T7. And coming down here, you will see the posterior superior iliac spine. So these are the posterior superior iliac spine. At this is your S2. And this iliac crest, at the highest level of the iliac crest is your L4. Okay, so these are the certain things which you can identify. So if you see the iliac crest, this is your L4. Okay, and the posterior iliac spines, at the level of your posterior iliac spines is your S2. So these are certain anatomical landmarks which you can use them to identify the levels of the vertebra. So this is how you identify the levels of the vertebra, right? And then what you have to test is for your next, the inspection, then the palpation. Then what you do is your testing. So there are various tests which you can do. So starting from the you have to do the inspection. Then you will go for the palpation. So next is your range of movements. So you are going to see the range of the movements, right? And then finally you will do certain tests which will help you to understand what is the type of the pain. So clinics, you have to understand that what we examine is what is clinics, right? So Sandhya, Kashyap, what exactly you want to learn then? Okay, so once the inspection and palpation is done, what you're going to test is for the range of motion, right? So this is very, very important, the range of motion. So how do you test for the range of motion? So you know that in the spine, we have flexion, we have extension, and then we have the lateral rotation. So rotations are not much appreciated. So mostly you look for flexion and the extension. And sometimes you can see the lateral bending like this. So this is the lateral bending to one side. Okay, so these are the various movements which you can identify in the case of the spine. Yes, we will include it, right? So this is the thing which you have to understand, that the inspection, palpation, range of movements and various tests. And so completing this range of tests, the most important, the next thing what you have to understand is this is the neurological assessment. So whenever you see a spine case or back pain, you have to understand that this is always sometimes associated with some amount of neurological involvement. So neurological assessment is very, very important. This only completes your evaluation of the back pain, right? So once you want to completely evaluate the back pain, so you have to do the neurological assessment. You have to complete the neurological assessment, and then only you can come to the conclusion, right? So this is how you do the physical examination. So these are the various movements which you have to test. So the first one is your flexion. Okay, second one comes to the extension, where you will see the ceiling. So you will ask the flexion is you ask the floor touch with the fingers. So this floor touching with the fingers, and here the important thing is it should be done in the knee extension. So it should be done in the knee extension, right? And then knee in extension, and then the backward bending. So extension of the spine is mainly the face looking towards the ceiling. So this is called the backward bending or extension. And lateral bending is towards the fibula. Your fingers touching the fibula is your lateral bending, right? And finally, you have rotations, which are not much appreciated, right? These rotations. So you can just simply ask the patient to look the sideways. So here the movement is only in the thoracic spine. The rotation is only in the thoracic spine. Okay, so these are the first one. What you have to see is for look for the inspection, the curves, the scoliosis and the kyphotic curves, and then you will do the palpation where you see the various tenderness points over the spinous process. First you will identify the most important vertebral points, then you will check for the tenderness, and then you will check for the various positions of the spine, right? So if you see all these points here, then you will check for the tenderness first on the palpation. And so one more thing what you can see is when you palpate all the spinous process, so you will palpate all the spinous processes here. And in case of spondylolisthesis, so what do you mean by spondylolisthesis? So spondylolisthesis is nothing but the protrusion of the vertebrae, right? So there is a protrusion of the upper vertebrae. So once there is a protrusion of the upper vertebrae, what you can feel is there is a step sign. So there is a step sign. So this you have to remember. So this is the vertebra. This is the second vertebra. And here what you're feeling the spinous processes of multiple vertebra, right? So in the spondylolisthesis, what happens? In the spondylolisthesis, this upper vertebra is protruding forward. So what will happen? The spinous process also moves forward. So when you are touching the spinous process of this and coming to this, you will feel a step here. So this is called the step sign, which is seen in spondylolisthesis. So step sign is seen in the spondylolisthesis. Okay. So tenderness, you can see the tenderness, or sometimes in the tuberculosis. Sometimes you can find the cold abscess also on your palpation. Right? So what is lateral bending? So lateral bending is sideward bending. So you're like this and you're bending. Your fingers will go and touch the fibula. So touching the fibula on the lateral aspect, this is called as the lateral bending. So this is flexion and this is your extension above, and sidewards this is your lateral bending, and these are your rotations. So these are all the movements of the spine. Okay, so these are movements which we have to demonstrate on the patient so that you will understand whether the patient is having any pain in the movements or any stiffness while bending. Is that clear? Yes. Now let us see the 3 important tests which you have to. Okay, what is a step sign? Step sign is mainly seen in a spondylolisthesis, a condition which is called as spondylolisthesis. That means there is a protrusion. So usually what happens is the vertebral column is in a straight line like this. Okay. So in listhesis, what happens is one vertebra moves forward compared to the upper one, right? So this vertebra is moving forward. And now, so if the vertebral column is straight like this, you're going to palpate all the spinous process in a line, right? So they're going in a line. But if there is this listhesis, so one spinous process is like here and another one is here. So if you want to palpate it, you have to go it as a step. So this is called as the step sign on palpation, which you see in spondylolisthesis. So cold abscess is nothing but it is just an abscess which is usually associated with tuberculosis. Usually this abscess will not have very high temperature. So these are not very warm, but warmth is still there, but not as hot as in bacterial infection, right? Yes. So that is about the palpation. This is about the movements where you check the flexion, the extension, and your lateral flexion and the rotation, right? And then we come to 3 important tests, the SLRT, and then you have the Faber or the Patrick test, and then you have your favorite modified Schober's test. So these three tests are very important. So first, foremost, most important is the straight leg raising test. So what is a straight leg raising test? So here what you do, the patient will sleep in supine position, okay, and now the examiner will lift the limb. So this lifting of the limb is nothing but there is a flexion of the hip. But what is more important here? Flexion of the hip with knee in extension. So knee should be in extension, and now you're going to raise the limb. So you're going to lift the limb this way. Okay, and lifting of this limb, what will happen? Whenever the knee is straight and you're lifting the limb, there will be stretching of the sciatic nerve. So the sciatic nerve stretches. So now whenever there is involvement of the sciatic nerve, that is in case of your prolapse intervertebral disc, at the lifting of 40 degrees, so 40 degrees, less than 40 degrees, the patient will experience pain. So whenever there is a pain of less than 40 degrees, so from 0 to 40 degrees, if the patient is having pain, wincing, then it tells you that this is SLRT positive. So this is SLRT positive. Okay, so whenever you examine a back pain, this is the first most important test your seniors or your professors want you to do. So you're going to do this SLRT, straight leg raising test. So straight leg means it is the knee in extension. So now you're going to raise the limb. While raising, if the patient is having pain of an angle of less than 40 degrees, 40 to 45 degrees, then it is a indication that you're dealing with the prolapse intervertebral disc. Above 45 to 60 degrees, there is no significance. There is no significance of the pain. So what you have to actually look for is wincing. So instead of patient telling pain, he winces with pain. Okay. Smaranyahati, rotations is nothing but rotation is just twisting like this. So this, the shoulders now are looking straight. Now they go like this. This is the rotation. And then this is the rotation. Okay. Rotation is limited in the spine, usually because of your thoracic spine they happen. Okay. Yes. So this is your straight leg raising test. And once your straight leg raising test is done, the second one what you have to do is your Faber test, figure of 4. So this is very important, and mainly important for which joint? This is mainly important to observe your SI joint. So now I have put the working diagnosis as ankylosing spondylitis, right? And now when I perform this Faber's test, also known as Patrick test, why it is called Faber? Because we are going to do this maneuver of flexion, abduction and external rotation. So all these three maneuvers we are doing on the hip, and hence whenever we do this hip and now you put the opposite hand and compress it or you distract it, the patient will have pain in the SI joint, right? So this is an indication of we are dealing with SI joint. So SI joint is involved. So that means whenever you do this test and if the patient is having pain or wincing with pain, so now the established diagnosis is ankylosing spondylitis. Okay, so once we have come with the working diagnosis of ankylosing spondylitis, on inspection you might not find anything. On palpation you might find tenderness on SI joints maybe, or some tenderness on the back, but on the rotations you will find there is a restriction of the flexion, right? And while doing this test, the Faber's test is positive in case of your ankylosing spondylitis. Faber's test or the Patrick's test is nothing but your flexion, abduction, external rotation, which is painful, and it indicates that we are dealing with the SI joint, the sacroiliac joint. And then to confirm your ankylosing spondylitis, we do this modified Schober's test. So you will identify a point, especially on the PSIS, that is posterior superior iliac spine, and then you will measure some 15 centimeters from there, right? And then you will ask the patient to flex. So on flexion, usually this increases. So this distance has to increase. Okay, but in ankylosing spondylitis, what will happen? There is restriction of flexion. Right, you know what is ankylosing spondylitis? Ankylosing spondylitis is nothing but fusion of the spine. The spine is not normal. There is no movements which is happening. So because of this restriction of the movements, you will find the space has been decreased. So this space has been decreased, right? So this is very important, and this is a confirmative test for your AS, ankylosing spondylitis. So there will be restriction of the flexion, right? Yes, so that is your modified Schauber's test. So we have three important tests, and whenever you do this SLRT, you know we are dealing with PIVD, or you're dealing with listhesis sometimes, where the nerve is involved, or you can also tell you were dealing with lumbar canal stenosis. Okay, so this is the test for all these three conditions, and whenever you're doing Faber's, it is for inflammatory or your Faber's ankylosing spondylitis, and your Schauber's is again for your ankylosing spondylitis. Okay, so that is how you come to a conclusion of the diagnosis. And now the neurological assessment is very, very important whenever you're dealing with the spine cases. Always the neurological assessment starts with knowing what is the bulk. So whether the muscle is atrophied or not. So atrophy is very, very important. You will check for the atrophy, the muscles, and then you will assess the power. So for example, you know that you're dealing with L4, L5 disc prolapse. So you will test for L4 and L5. So what does L4 and L5? You will test for ankle dorsiflexion and great toe extension, like that. And for L5, S1, again there is an ankle reflex. So that is why you have to do the proper neurological examination. So now let us assume there is one more interesting case where the patient is 32 years old. Okay, 32 years old. Now it is a female patient, right? Complaining of low back pain. Okay, and then there is sciatica. Okay, now the patient is having sciatica, and now this sciatica is again associated with tingling and numbness. Okay, low backache, sciatica, tingling and numbness, and increased with weightlifting. So any lifting of the weight, patient will have increased weightlifting, right? So patient will have increased pain. So this is the history. So this is the history we have taken. And now on the examination, the inspection and palpation, we have come to know that the SLRT, so the straight leg raising test, is positive. Okay, the straight leg raising test is positive. So this is straight. Smaranya, what do you want to listen about the last test, that is the Schauber's test? So Schauber's test is mainly for measurement of the flexion. So it will tell you whether the lumbar spine is able to flex or not. So lumbar spine flexion is tested by this Schauber's test, right? So how do you test it? So first you will mark a point A and then a point B. Right. So from A to B, if it is 15 centimeters, on flexion, usually it is above 15. That it should be 16, 17, 18, like that. But if it is below 15, that means there is a restriction in flexion. So there is a restriction in flexion. That is what the Schauber's test will tell you. So whenever there is a restriction of the flexion in lumbar spine, this is mainly your ankylosing spondylitis. Okay. Is that clear? Smaranya? Yes. And then now I've told you that this is a case scenario of a 32-year-old female coming with the, a low back pain, and now there is a sciatica, that is, the pain is radiating from the buttocks towards the great toe. There is associated with tingling and numbness, pain exaggerations with pain. And now she tells that SLRT is positive. On examination, you have seen that SLRT is positive. So now what is your working diagnosis? Yes. What could be your working diagnosis for this patient? No step sign. And on examination, there is no step sign. And there is no claudication. No history of claudication. Okay. So what could be your working diagnosis for this particular patient? Yes, waiting for your answer. So what could be the working diagnosis if the patient is a female patient of 32 years, now has come with low back pain plus, radiating pain, and on the examination, that is palpation, you have seen there is no step sign and there is no claudication also, but SLRT is positive. So what do you think can be this? What do you think is this? Yes. Yes, I'm waiting for your answers. Yes. What could be this? So here I'm talking about. Very good. Yes, this is your prolapse intervertebral disc. Yes, exactly. So I've given what all is required here. So I've given a lot of clues. So here this is straightforward a prolapse intervertebral disc. So what made you tell so? So here the patient was having a low back pain and a radiating pain. That is sciatica, radiculopathy, yes, associated with tingling and numbness, and there is an exaggeration with the weight lifting, and most importantly the SLRT is positive, which will tell you that you're dealing with a disc prolapse, right? So this disc prolapse, this SLRT can be positive in lumbar canal stenosis and listhesis as well, but I've clearly mentioned that there is no step sign and there is no claudication. So the answer straight away would be your prolapsed intervertebral disc disease. And now you have to tell me which level is this disc prolapse happening. So the disc prolapse can be anywhere from L2, L3, L3, L4, L4, L5, L5, S1, right? So which level is this PIVD? So to understand which level is the prolapse intervertebral disc, so you have to do the neurological examination. Radiculopathy is a symptom, that is not a diagnosis, right? So radiculopathy, this is radiculopathy. Who said it is not? It is radiculopathy. Whenever I say there is a radiating pain, involvement of the sciatic nerve is radiculopathy. Yes, you can ask whether there is paresthesias or not. So usually they tell the paresthesias are present. Yes, paresthesias are present. And now this is important, that if the paresthesias are present and there is some involvement of the disc, now it is your responsibility to know which level is this disc present, right? Which level. So to understand that level, you have to examine the lower limb. So you are going to examine the lower limbs, because the lumbar plexus, it supplies the lower limbs, right? So now you will see the thigh muscles, the leg muscles, the calf muscles, right? So in the thigh muscles you will see the bulk, whether there is any atrophy or not, and then you will assess the power. So you will see the hip flexion. So power, the MRC grading. So MRC grading, 5 4 3 2 1 0. Okay, so how do you assess the power? So first you will ask the patient to do hip flexion. So hip flexion is, you're putting the thigh over, right? So you're pulling the thigh towards the abdomen. So that is the hip flexion. And then the knee extension. So you will grade the power accordingly. So you will test for flexion of hip, extension of the knee, dorsiflexion of the ankle, big toe, that is great toe extension, and ankle plantar flexion. So this is L2, L3, L4, L5 and S1. So whichever level it is weak. So for example, let us assume that this is a disc prolapse of L4 and L5. So whenever we are dealing with L4 and L5 disc prolapse, so you will see that there is some abnormality in the ankle dorsiflexion, because L4 is ankle dorsiflexion and great toe extension is L5, right? So whenever you see let us assume that we are dealing with a disc prolapse at the level of L4 and L5. So now you will see that L4 is ankle dorsiflexion and L5 is great toe extension. So now which one would be weak? Is it ankle dorsiflexion or great toe extension? So which nerve will be affected? Is it L4 nerve which is affected or L5 nerve? In L4, L5 disc prolapse. So that is my question. Okay. Which nerve will be affected? So I'm telling you that this is the vertebrae. So these are the vertebrae, right? So this vertebrae, this is L4, L5 and S1. So this is the disc here. Okay, this is L4, L5 disc and this is L5, S1 disc. So there are nerves coming out like this, right? So which nerve will be affected here? Is it the L4 or L5 nerve or S1 nerve? Which nerve will be affected? Yes, very good. So it is the L5 nerve which is getting affected. So what will be the answer here? Which one will be weak? So the great toe extension will be weak. So in the question, what will they give you? They will give you that. So the patient will having SLRT with the great toe weakness. So whenever they mention about great toe weakness, that means the L5 nerve has been affected. So this is the disc of L4 and L5. So L5 is affected. So why L5 is affected? Because L5 is the nerve which passed through the disc. So imagine that this is L4 and this is L5. So here we'll having this L4, L5 disc, right? So whenever there is a disc prolapse of L4 and L5, you see the L4 and this is L5. So L4 nerve will exit and this L5 nerve will traverse. So always remember, yes, Sinosmarania, you will ask this. So that is why remember there are two important nerves. L4 will be the exiting nerve root. L5 will be the traversing nerve root. So always whenever there is an L4 and L5 disc prolapse, the lower level will be affected. That is L5. Okay, so the lower level is L5 which will be affected. So this is again an important thing which you have to remember, the exiting nerve root and the traversing nerve root. The exiting nerve root is L4 and the traversing nerve root is L5. So the L5 will be near to the disc and then it gets affected. So just remember whenever there is an L4, L5 disc prolapse, the lower level, that is L5 which is affected. And now you can also see the L5 is involved in the ankle reflex. So the ankle reflex will also be sluggish. So you have to remember depending upon the level, so which weakness is present. So you have to examine for flexion of the hip, extension of the knee, dorsiflexion of the ankle, great toe extension and ankle plantar flexion. And then you should also look for the sensations. So if you see all these sensations accordingly, if it is an L5 sensation, it is this area where the sensations, the paresthesias are mainly present in that particular area, that is L5. Okay, and if it was S1, so S1 is this particular area. So S1 is usually the lateral part of the foot, lateral part of the foot. So this you have to remember for the sensations. L4 is usually the medial. And L5, if you see, the first dorsal web space. Okay, so these are the areas which you have to remember for the sensations. Okay, so here you will examine the motor weakness, the hip flexors, extensors, ankle dorsiflexors, and then you will see for the sensations. So sensations, L4 on the medial aspect of the dorsum of the foot, S1 on the lateral aspect of the foot, L5 is the first dorsal web space. And then you will check for the reflexes. So two important reflexes in the lower limb, the knee reflex and the ankle reflex. And then you have to look for the anal sphincter tone. So this is mainly for what? This is mainly for your saddle anesthesia S3, S4 and S5, and to understand the cauda equina syndrome. So for the compression syndromes, the most important one you have to remember is the cauda equina syndrome. So there you have to examine the perianal sphincter. So perianal anesthesia. So that is S3, S4 and S5. Okay. So this completes your neurological examination. So once you finish the history, then you finish the diagnosis, I mean the physical examination. So you come to the diagnosis and it is complete only with the neurological assessment. So all the three steps you have to follow. First is history, physical examination, and then your neurological examination. So this completes the diagnosis. And now once you're done with the diagnosis, you have to look for the red flag signs. So what are the red flag signs? So these are certain red flag signs where you have any history of trauma, any recent history, unexplained weight loss, fever, cancer history, osteoporosis, age is very high of more than 70 years. If there are multiple focal neurological deficits, on neurological examination, you see there are certain disabling symptoms, and if there is any prior surgery of spine. So all these are the red flag signs. So that means you have to evaluate them more deeply, and you have to always go for imaging. Right? If the history is not proper, if the physical examination is not helping you, you have to look for these red flag signs and you have to go for appropriate imaging. So when it comes to imaging, the first one what we take is the X-ray. So X-ray is very important. We go for the spine, and based upon the spine you will order whether it is a DL spine or it is a LS spine, right, or it is a cervical spine, okay, or it is a plain thoracic spine. So you have to mention, so X-ray of which particular area you want to see. So usually in spine we go for AP view and a lateral view. So AP view and a lateral view we use, and in that we will try to identify what are the features of that particular X-ray. So here you can see whether it is an infection, fracture, malignancy, listhesis, disc space narrowing, or any prior history of surgery. So this is a normal X-ray of the spine where you see in the AP view. So this becomes your AP view and this is your lateral view. So in the AP view you can see the whole of the vertebrae, and clearly you can see these two are the pedicles, and this is in center is your spinous process, right? So you have the pedicle, the spinous process, right, and and here you will have the transverse process like this, okay. And on the lateral view what you can see is this is your pedicle, okay, and then this is your whole of the vertebral body, and more interestingly the disc space. So this is the vertebral bodies and this is your disc space. So this is the disc space, okay. So vertebral body, disc space, and these are your pedicles, these are your facet joints, okay. So these are all the features which you look for, and you see the most important thing, anything on the which is called the spondylosis. So what do you mean by spondylosis? It is nothing but degeneration of the spine, okay, degeneration of the spine. So cervical spondylosis, lumbar spondylosis is nothing but your degeneration of the spine. So how do you identify? The most interesting fact is reduction of the disc space. So whenever there is a reduction, that means the intervertebral discs are collapsed. So you will have reduction of the disc space associated with the osteophytes, okay, associated with the sclerosis. So all this will tell you that you're dealing with the spondylosis. So this is the reduction in height. You can see the height here. So this is the height, and there is a decrease in the height. So this is what you meant by reduction in the disc spaces. So sometimes you can see the vertebral body is completely collapsed. So this is nothing but your fracture. Okay, so this is nothing but your fracture. So here you see the vertebral body height is completely decreased. So normal vertebral height is this. So here it is completely collapsed. So this is a X-ray of the fractured disc. So this is X-ray of the fracture vertebra. Okay, then what do you mean by spondylolysis? So lysis is nothing but there is a break. So where there is a break, so there is a break in a very important structure that is called break in pars interarticularis. Okay, break in pars interarticularis. So that means spondylolysis. Lysis is break, and listhesis is whenever there is a break. Now the vertebrae can move forward. So if you see, this is the vertebra, this is the vertebra. Now this vertebrae moves forward. Okay, this vertebrae now comes here. Okay, so this, if you see, this is the movement of the vertebrae. Okay, so this is called listhesis. Spondylolisthesis means the vertebrae moves forward because there is a break in the pars interarticularis. So losis, lysis, and listhesis. If the X-ray doesn't give you a good, diagnosis, then you can go for a CT scan. So for certain fractures, usually for trauma, we go for CT scans, right? But for soft tissue viewing, so if you want to understand the PIVD, so in prolapse intervertebral disc, or you want to understand the canal anatomy, you always go for MRI, right? So neurological symptoms are present, any problem with the neurology, you have to go for MRI. Any problem with the bone anatomy, so you want to read about the bone, if there is a fracture, you want to understand the fracture pattern, you want to read about the vertebrae, the facet joints, then you can go for your CT scan. So this is the bone CT scan, then you have MRI scan, and finally the most interesting thing is you can see the sacroiliac changes also in the MRI, mostly not seen on the plain radiograph. So to diagnose as your ankylosing spondylitis, you have to see the changes on the MRI. Okay, and then finally you have to deal with any occult infection or a neoplasm. Usually we use for a bone scan. So for bone scanning, what we do to identify the occult, if the x-rays are normal, if the SR is normal, then you can go for radionuclide bone scan for initial diagnosis. So very early diagnosis, you can go for the bone scan. So these are the certain investigations. So now we have prepared the history, we are done with the examination, and then on the investigations you will find and come to the conclusions. So these are the various symptoms or signs, and now these are the various conditions where you can diagnose. So the first one would be most of the conditions. So 80% of the people with the low back ache will present with this strain, so musculoligamentous strain. So now the most classical example is the flute guy who is disturbing us. He is having a pain, low back pain. So this is clearly the musculoligamentous strain. Okay. So this is, yes, it is musculoligamentous strain. So usually, yes, people like him, when they attempt gym without proper guidance or without proper, warm-ups and all. So most commonly the condition would be musculoligamentous strain. So all this, so whenever you examine, do history, everything would appear to be normal. And now the patient, there would be some limitation in the movement. So usually the muscles get strained, so they will limit the movements. So the most important thing is the musculoligamentous strain. Okay, you got the answer, Dr. Flute Guy? Yes, this is musculoskeletal strain. That's it. And then fibromyalgia. I told you, some amount of psychological dependent. This is fibromyalgia, where you have a very widespread of pain. There is no specific point, and patient will have whole of back is paining, whole of legs are paining. There is no specific tenderness. So everything appears to be very painful to them, and most of them, they won't be happy with what amount of medication we give. So usually we categorize them into fibromyalgia. Okay, and then your osteoarthritis, as I've told you, there you can go for an x-ray. So in this x-ray, what you see, you will see spondylosis. So you will take an x-ray, you will see there are multiple osteophytes, decreased disc space, and then the muscles gets compromised, and then the patient will have pain. Okay, so osteoarthritis of spine is most common thing. And then comes the rheumatoid arthritis. And rheumatoid arthritis, you have to remember this condition, it is mainly seen in the cervical spine. So rheumatoid arthritis is mainly for the cervical spine, and in the cervical spine, it mainly importance is in the atlantoaxial instability. So whenever the patient is having rheumatoid arthritis, and now you have to ask them specifically, are they having any pain in the cervical spine? So rheumatoid arthritis specifically affects the cervical spine. And then comes the most three interesting features. So first one is listhesis. I have told you listhesis is protrusion. So now the patient will have a dull aching pain, and pain usually extends into the buttock. So if there is an involvement of neural canal, then they will have symptoms of paresthesias, weakness. Okay, paresthesias, weakness, all this will happen. Fine. Rest. So the treatment mainly for the musculoligamentous strain is usually you have to give a period of rest followed by back strengthening exercises. Okay. Yes, and then if the patient is having weakness, paresthesias, and you have the step sign on examination in the palpation, then you can think of spondylolisthesis. And then compression fractures. So these compression fractures are more common. This is nothing but your osteoporosis. So mainly in the elderly female, you have this compression fractures. So again, patient will have tingling, numbness, and weakness, and usually what they have is low back pain. So usually the complaint will be just a low back pain. Okay, and sometimes the osteoporosis can be associated with kyphosis also. Okay, you have to look for this, the curve on the patient who presents with the pain, and once the patient is having any curves and tenderness over that particular vertebrae, you have to go for the x-ray. And inflammatory, you know very well, we have dealt with ankylosing spondylitis, and reactive arthritis is not very much common in the spine. So ankylosing spondylitis is one important thing. And usually, how do you differentiate between ankylosing spondylitis? I've told you the early morning stiffness. So this is very important. And age is usually less than 40 years, right? And then early morning stiffness and enthesitis, right? So these are the two things which will tell you that you are dealing with the inflammatory condition. So it is a chronic pain, very insidious onset, and you will have early morning stiffness, and usually they will have the enthesitis, other associated problems, right? So then you have to think about the inflammatory conditions. If all these are not there, then you can go for other specific causes. So what are the other causes which I'm telling? So other causes can be involvement of, okay, thank you. So other causes would be myelopathy. So what do you mean by myelopathy? Myelopathy is whenever there is a spinal cord involvement. Directly spinal cord is involved, then you will have cervical myelopathy. So the patient will have severe weakness, right? So there will be weakness of the upper limbs, severe pain in the cervical spine. So all this will be there. What is radiculopathy? A single nerve root when it is involved. For example, only L5 nerve root is involved. So that is called as radiculopathy. And then you can have disc herniation. So PIVD. Okay, and then other causes like metabolic, you have Paget's disease, osteomalacia, you can see in vertebra, right? And then metastasis. So whenever I deal with metastasis, neoplastic, it is the most common one is metastasis, right? You have to remember this. So there are lung, breast, prostate, multiple myeloma and lymphoma. All this will spread to the spine. So metastasis is one of our very, very important. Okay. And then infection. Infection, you have the TB or the osteomyelitis, right? So these two are very, very important, the TB and osteomyelitis, and rest you can have your Lyme disease, CMV and HIV, and the referred pain. So usually most common thing which is referred is nephrolithiasis. So usually renal stones. So whenever there is renal stones or sometimes this pyelonephritis, so infection of the kidney and the renal stones are one important referred pains where you have to look for. Okay, and aorta is the big one which is present. So aortic dissections, aortic aneurysms also can present with your back pains. And most important and usually neglected are postures, ergonomics as we have discussed, stress, depression, overweight, smoking, sometimes pregnancy. Okay, so these are all the non-specific causes of the low back pain. So you can have pain because of prolonged sitting, prolonged standing, overweight. So whenever there is an obese patient, so the tummy goes front, right? The stomach moves front. So that is why the curvatures of the spine are disturbed. That is where they land up with the low back pain. And long-term steroids, you know already, so they they land up in the osteoporosis, and then they can have pain. So pregnancy, again, because of stretching, so there is a lot of overweight on the anterior side, so the spine has to compensate on the back, so then the patient will have the low back pain. So these are certain non-specific causes of the low back pain. And finally, we come to a conclusion to first understand what is the priority. So you will always start with the gait. So as soon as the patient enters, you will look for the gait of the patient, and then you will do proper inspection. So what is the alignment, what are the curvatures, then do palpations, then do range of motions and special test. And still here, so once you come up to here, so from the inspection, So palpation, range of motions, and the special test, you will come to a diagnosis. So once your diagnosis is established, then you confirm it by your investigations, right? And then you evaluate the patient. Okay, so what is this important gait? So gaits are multiple types. Gait is mainly for the hip joint, but sometimes in the spine also you can see such gaits that towards, whenever the patient is bending towards one side, there is a, pelvis is drooping to the one side. This is called as your Trendelenburg gait. Not very important in the spine, but these are certain types of gaits which you can witness in patients with low back pain as well. Okay, so this is the important slide which you have to remember. So various conditions of low back pain. So this is the slide which is very, very important. So there could be a muscle pain, fibromyalgia, I've told you, multiple points pain, osteoarthritis, ankylosing spondylitis, listhesis, compression fractures, and then this could be certain non-specific causes for it, but very, very importantly, you have to rule out whether this is a prolapsed intervertebral disc disease or a Paget's, Malaysia, osteomalacia, or a TB disc, or sometimes a referred pain which could be from pancreas, especially from the kidney, urinary tract, and then your aorta. And non-specific causes, these are the non-specific causes. Always put in mind, because 70% of the low back pain are from the non-specific causes. Fine. So this is up to the back pain. Hope you all understood. Any doubts? So you can always put your questions or queries on the Instagram handle Dr. Alekhya Ortho or PW Meded. Right, so all your queries will be answered. So anything you want to know? So this is how you evaluate a back pain whenever you see it and in the OPD. Okay, so next class will come up with the knee pain or the joint pain. Okay, see you all in the next class. Keep learning. Thank you.